leave this better understanding of how things are supposed to work in DC and how they're actually working. Each year, the government Congress drafts 12 separate appropriations bills. Among them are the Labor, Health, and Human Services Bill and the Transportation, Housing, and Urban Development Bill, which contain the bulk of HIV-related spending. Once that has happened, there are votes on each of those bills in their respective chambers, and amended versions are passed by both the House and the Senate. The House requires a simple majority vote, and the Senate requires 60 votes, and in most cases, bipartisan agreement. Once those bills have been conferenced and there's agreement on the combination of those two bills, a final package is voted on by the House and Senate, and if it passes, it is sent to the president to sign into law. The president can veto that bill, at which point it will go back to Congress, where a second vote would need to take place with a higher majority threshold, but that very rarely ever happens. Once the president has signed the legislation into law, the Office of Management and Budget within the Executive Office of the President takes money from the Treasury to send to the individual agencies throughout the federal government, who in turn then go about the process of distributing that funding to the public health departments and private organizations as grantees. There are normally open grant processes to distribute this money, where the agencies post notices of funding opportunity, and then the health departments or private organizations provide grant applications to see if they can receive that funding. And if they win, they're then distributed that money by the individual agencies, either directly or through a third party. Next slide, please. That is not how things have been going in 2025. Very few parts of the system have worked as they have been designed to work over the last 9 months, and this is in many ways by design by the Trump administration and by congressional Republicans. In the previous fiscal year, the one that we were just now finishing up and which ends on September 30th, Congress could not come to an agreement on a new suite of appropriations bills for FY25. The bills from the Republican-led House were far too conservative for Democrats to get on board with, and the gulf was too wide between them and those in the bipartisan Senate bills to reach an agreement. And so we had what is called a continuing resolution that went for the rest of fiscal year 2025. This is when the spending numbers from the previous fiscal year are just carried forward into the next fiscal year and used as the basis for distributing the funding. In this process, what this in effect did was remove a lot of the language that was included in reports that accompanied the previous fiscal year's funding agreements, and provided the Trump administration with much wider discretion as to how they will spend the funds appropriated by Congress, and in addition to their own possibly unlawful actions to cut funding in other ways, and to decrease the ability of grantees to receive those funds. So at the same time, this long-term continuing resolution, or CR, was being passed, you had the Trump administration sending out cancellations of billions of dollars of grants to grant recipients, stating as for reason of cancellation, a series of executive orders that the administration had put forward targeting communities, many of whom are folks that we serve and are a part of. So all of these executive orders from earlier in the year that we saw targeting transgender communities, targeting immigrant communities, more recently targeting individuals experiencing homelessness or dealing with mental health or substance use disorder issues, targeting diversity, equity, and inclusion initiatives and things that address racial justice and mental health equity. All of these things were used as a pretext to cancel many grants that serve our communities. At the same time this was happening, the administration was also going through a mass, what is known in DC as a reduction in force, which is a fancy parlance for saying firings, for large swaths of the federal government, including the Department of Health and Human Services, where most HIV programs are held. Over the last 9 months, we've seen roughly a quarter of all Health and Human Services staff fired or resign from their positions, as well as significant cuts to the infrastructure of these various agencies. Roughly half of the divisions within the Division of HIV Prevention were eliminated by the administration, as well as portions of the Division of STI Prevention, viral hepatitis prevention, and other related infectious disease programs. All of this had the effect of making it so that it was incredibly hard for the folks that were remaining in the federal government to distribute funding to grantees in a timely fashion. A lot of grantees received funding late, or they received funding as a partial award, only to receive the rest of their funding later. For many Ryan White recipients, particularly folks with Ryan White Part F grants, so those are the AIDS Education and Training Centers, special projects of national significance, and the dental programs. Some of that FY25 funding wasn't released until last week. So more than 11 months into the current fiscal year. Again, this is all part of a process to try and gum up the works and make it harder for programs that serve communities that this administration does not value to provide those services. And there are a host of other ways that they're trying to do this around things like rescissions, where the administration sends back a list of programs they would like Congress to cut that they had previously said they would already fund, and have a second vote on that can be voted on by a simple majority rather than 60 votes, or a very legally dubious process known as a pocket rescission, where the administration puts forward a rescission request within a certain amount of time before the end of the fiscal year and just allows it to lapse, with the idea being the fact that if the rescission request is still active when the fiscal year ends, and those monies just vanish, disappear. The long and short of it is this has made it extremely hard for organizations and public health departments to plan ahead for both staffing and programmatic functions throughout their organizations when they don't know if they're going to get their money or when they're going to get their money. And so it has been very difficult for things to go on as usual as we see all of these attacks both on our funding and on our basic rights coming from this administration, often greenlit by Congress. Next slide, please. Just wanted to point out that there are so many different ways in which the federal government supports people living with and infected by HIV, and that all of these things are interrelated. As you can see here, we've got Medicaid, Medicare, the Ryan White program, services for people living with substance use disorder, mental health issues, and SAMHSA, housing through HOPWA, food security through SNAP, research through the National Institutes of Health. All of these things are part of a broader structure that provides us with the systems that are necessary to reduce new HIV transmissions and provide services to people living with and infected by HIV so they get the best care possible. When one aspect of this is cut, it is felt in all of the other programs, as I think will be discussed later on in this webinar. HR 1, the one big brutal bill that was passed by congressional Republicans and signed into law by the Trump administration back in July, had tremendous cuts to Medicaid that we will begin to experience very shortly. Those cuts to Medicaid are not just confined to that program or to CMS. They are going to be felt throughout the system, particularly in a program like Ryan White, who, as the payer of last resort, is going to see a lot more folks living with HIV who have lost care through Medicaid, seeking care through Ryan White. And since Ryan White is a discretionary program that has only about as much money as Congress provides it on a yearly basis, will need to be providing the same amount of services to more people with the same amount of money, which is an impossible task. And so just all of these things are really interconnected. And next slide, please, before I hand it off to Ronald and Jeff. But another representation of the ways in which all of these things work with one another to provide the system of care that we need, and how we need to, as a community, both as part of organizations and in concert with our elected officials and with public health departments across the country, figure out ways to plug these gaps during periods when these programs are under attack, and then learn how to build bigger, better, more nimble systems to provide services to folks in the eventual circumstance that we are able to fight back and create new pathways to care for these systems. So all of these things, from HIV prevention funding to Ryan White to Medicaid, have unique impacts on folks that are going to be felt across the spectrum of public health. And want to pass it over now to Ronald and to Jeff to talk a little bit more about the direct experiences that folks living with HIV have been experiencing over the last 9 months, and what that means for our advocacy in our community.
Thanks, Drew. And thanks all of you for joining today's AIDSWatch session. In the next few minutes, Jeff and I want to talk about how the political landscape and the climate in this country that we're experiencing impacts the lives of those of us who are living with HIV. The over 1 million people living with HIV in the United States today. And we want to specifically talk about how the polarization and divisiveness that we are seeing in our landscape, both politically and socially, impacts people living with HIV. And we want to go a little deeper into what the administration and Congress in its appropriations, the directions that we are seeing, and how they impact and will impact people living with HIV. To get us started, I'll pass it to Jeff, who will talk about how the divisiveness and and polarization that we are seeing impacts people living with HIV. Jeff.
Thank you, Ronald, and thank you, Christina and AIDS United, for that nice introduction and for the opportunity to speak here today. As Ronald mentioned, we are indeed seeing increased polarization and divisiveness from the top down. I will, kind of like to, center this in the sense that I don't think we are necessarily as divided as it appears as a country, as a people. And so, but we are hearing this rhetoric from the political elected officials. And, in this current political climate, it includes the undermining the concept of diversity, equity, and inclusion, or DEI, and increases the vulnerability of populations most impacted by HIV. I think this is most notable in the continuing stigma and discrimination of people living with HIV or perceived to be impacted by HIV, namely anti-LGBTQ plus laws that have been introduced in several states, and HIV criminalization laws that still exist in over 30 states. I was on a call yesterday where, this really emphasized that there still exists this stigma and discrimination all these years later. And on the call yesterday, we were asked, a group of us, the speakers, to comment on how stigma has changed over time. One person said it hasn't. And we still are facing stigma all these years later. I think it's changed a little, but it's just as strong and powerful today as it was then. I think back back in the early days of the epidemic, we were fighting for equality as LGBTQ plus people, as well as for HIV. And so there was hope on the horizon. And right now, that hope on the horizon seems a little more distant. And so I think that's, for me, what's different. In Timothy Snyder's book, if anyone's read On Tyranny, the first chapter is Do Not Obey in Advance. And we've seen with the attacks on universities and mainstream media, on law firms, examples of some that have indeed, bended the knee and obeyed in advance with a lot of these programs. And but there are some examples of those who have not and fought back. And we're very fortunate here in Illinois. I'll just say we have elected officials who are finding ways to fight back. And case in point, the National Guard troops the administration threatened to send did not, in fact, come to fruition because of that resistance. So resistance is not futile. And I'll hand it back over to you, Ron.
Thanks, Jeff. I want to talk a little bit now about, next slide. How the disruption of healthcare and treatment and essential social support programs that we are seeing in the Trump administration, the actions that have been taken in just the first 8 months of this second term. Specifically, the actions that the administration has taken to close some of the offices that are directed and deal with HIV. Specifically within HHS, the administration has eliminated the office that deals with HIV policy, the CDC's Division of HIV Prevention, and the Administration for Community Living. And I cite that as an example, most notably because over 50% of people living with HIV are 50 years and older. And that proportion and the number of older adults living with HIV will be growing over the next couple of years. So the lack of support that the Administration for Community Living's elimination really suggests that the attention and the focus of the federal response is going to be weakened, is being weakened. And this really creates a degree of uncertainty among people living with HIV as to how reliable the programs and services that are saving our lives will be over the next couple of years in the administration. Also want to talk about some of the funding programs and how the congressional actions, the appropriations that Drew talks about, again, creates a degree of uncertainty among people living with HIV. The funding levels in the FY 2026 appropriation bills that Congress will be looking at now and over the next couple of months, the president's budget that has proposed, where he completely eliminated funding for ending the HIV epidemic, the flat funding that we're seeing proposed for the Ryan White program, and the elimination of Part F in the president's budget. Also combined to, again, as I said, create uncertainty about the reliability of programs, the Ryan White program, HOPWA, all of the federal response that has made such a difference in saving our lives and being able us to live and have a good quality of life. These programs are being threatened by the actions of the administration. And one major bill, HR 1, that has been passed, the so-called Big Beautiful Bill, also has some specific threats to the care programs and to the lives of those of us living with HIV. And I'll turn to Jeff to talk about a little bit about what the HR 1 can mean, particularly in terms of Medicaid and private health insurance.
Thank you, Ronald. HR 1, so in the context of the US Congress, HR 1 stands for House of Representatives 1, and it's a bill number assigned to a major legislation by the party controlling the House of Representatives. So because the number is reused every 2-year congressional session, there have been several different bills known as HR 1 over time. As Ronald mentioned, this session of Congress, HR 1 is also known as One Big Beautiful Bill, which I really hate to even say those words, so I'll say OBBB if I could, after that one's spelling out of what it stands for. But so HR 1 or OBBB cuts billions of dollars from Medicaid over the next 10 years. The bill also includes work requirements for adult Medicaid beneficiaries, which we're going to see ageism in that, because a lot of the work that I do and some of us do is around HIV and aging, and there's going to be ageism for people trying to go back to work because of these work requirements and being turned away from potential jobs. So hopefully we don't, we want to not have those work requirements in place, but if they are, it's going to be compounded by that. These provisions are projected to result in millions of people losing their healthcare access. Since Medicaid is the healthcare insurer, over 40% of people living with HIV are on Medicaid. The HR 1 provisions are likely to cause several thousands, tens of thousands of people living with HIV to lose healthcare access. And, we can't let that happen. And so the other thing that HR 1 also reduces premium tax credits that make private health insurance purchased in the marketplace more affordable. So again, this will likely result in more people living with HIV losing private health insurance, which in turn could result in people living with HIV losing access to health care. And all of this is, even if you have private health insurance, these cuts to Medicaid are going to affect all of us because the pool becomes smaller and then premiums go up. And so more people will be impacted than just people on Medicaid. Ronald, I'll turn it back to you.
Thank you. And again, all of these cuts in federal funding, the potential cuts, the $2 billion cuts that are in the House's appropriation bill for the programs served by the Health and Human Services, really, as I said, undermine the reliability of care and treatment for people living with HIV. And it is certainly something that through AIDSWatch in Washington and at home, we need to bring to the attention of our members of Congress. These impacts cannot be lasting. We have to reverse the course and increase the federal response and not to see the retreat that we are experiencing now in these first 8 months of the Trump administration. And with that, I'll pass it on to the next slide.
Thanks so much, Ronald. Hi, everyone. My name is Marianne. The landscape, having just heard from everyone, the landscape is having an immediate impact on our communities. And for the next couple slides, I'm going to highlight ways that it's having an immediate impact on providers and the public health system at large. So if we can go to the next slide, please. So for when we know that providers are facing a lot of uncertainty, abortion has long been a targeted health service, and we are continuing to see that on the national landscape. HR 1 included a 1-year ban on state Medicaid payments for some abortion providers. The description that was included in the law applies to the overwhelming majority of Planned Parenthood health centers and possibly some other independent abortion providers, such as Maine Family Planning. The provision is time limited to 1 year, and we do have multiple lawsuits in play, but the landscape shifts every single day. So, for example, Planned Parenthood had previously won a temporary stop on this provision, but yesterday that stop was overturned by the First Circuit Court of Appeals. But big picture, moves like these are part of a much larger and longer playbook of stopping healthcare providers from being able to provide abortions. We saw this in Trump's first and second campaigns, in Project 2025. We are also continuing to see it from statements that come out from the offices of various members of Congress. We also know that providers are facing a lot of uncertainty when it comes to being able to provide gender-affirming care. This administration is attacking gender-affirming care providers from all angles, but currently has a particular focus on those who provide gender-affirming care to youth. As folks may know, 27 states and 1 territory have used state laws to ban best practices for surgical and/or medical gender-affirming care for minors. And so healthcare providers are literally moving out of these states to avoid these restrictions and penalties, and are putting a lot of families in a situation where they're either moving out as well or regularly traveling out of state just to access this life-saving care. The federal government has launched investigations into many facilities that provide gender-affirming care to youth. Some of these investigations and statements imply that providing gender-affirming care to youth is inappropriate care and would endanger a facility's ability to participate in federal programs like Medicaid. And so this really pits the provision of gender-affirming care against the ability for other forms of care to be provided at a hospital or a doctor's office. So a lot of hospitals are facing a big question of, do they continue providing gender-affirming care to minors in light of this major financial risk and potential federal investigation? And so what we've seen is that a lot of big providers like Children's Hospital of LA, University of Michigan, et cetera, have announced either the closure of their gender clinics or some kind of significant scale back of the services that they provide. And so in addition to kind of just seeing the loss of care in certain states, we're also just seeing it across the country as well. And then we are also seeing a shift in preventive care. Folks probably know that the coverage of preventive care is often guided by the recommendations of national working groups that are groups of experts that are familiar with the relevant science. The Secretary of HHS, Robert Kennedy Jr., has shifted the membership of at least one of these groups, already appointing folks that have openly criticized and have been paid witnesses in cases against vaccine makers. So it's difficult to know the exact future of preventive care recommendations, especially in light of the fact that we know there are folks out there who object to forms of life-saving preventive care, including PrEP. As of now, we haven't seen any attempts to revise the current PrEP recommendations, but advocates need to be vigilant and encourage state legislators to protect access to preventive care at the state level wherever possible. We'll move on to the next slide, please. We're also seeing broader themes here. So one being that there are more restrictions on accessing healthcare coverage coming down the line. So HR 1 rolls back healthcare coverage options for certain groups of non-citizens, such as asylees and refugees. This includes impacted eligibility for Medicaid, Medicare, ACA marketplace subsidies, and SNAP. And the administration has also recently announced that it continues to further reduce non-citizen eligibility for certain safety net healthcare and social services generally. HR 1 also requires states to condition Medicaid eligibility for adults in the ACA expansion group to meet work requirements, or more aptly named paperwork requirements. These changes are delayed. They might not happen until 2027 and will include some exemptions, but the devil's really going to be in the details to make sure people don't inherently slip through the cracks and get penalized for not being able to submit their paperwork in time. We're also going to see more fear in accessing healthcare services in general. Anyone who's been following the news also knows that this administration has dialed up openly hostile and aggressive law enforcement when it comes to immigration. This administration has rescinded guidelines that previously limited immigration law enforcement in sensitive locations, such as healthcare facilities. And we know that these kind of policies can have a chilling effect as to whether people engage in the healthcare system at all and whether they're able to get the resources they need to manage chronic conditions. Will someone be willing to go to a doctor's office if they know that ICE might work with medical staff to detain them? We're also seeing with all the federal investigations of hospitals that provide gender-affirming care to minors, parents who and youth who are appropriately concerned about what this means for their child's information and their ability to get the care they need. And then finally, there's also consequences that we haven't quite realized yet going forward. For example, the administration has made moves to eliminate data collection and research tied to DEI initiatives, including research that captures disparities faced within the LGBTQ communities. Erasing identities from research can have a long-term impact because data matters. We need it to capture the impact of health issues, to study the safety and efficacy of public health interventions, to determine whether health disparities exist, are improving, or getting worse. And we need good data and the ability to see those trends. And so there are probably more consequences that we won't see until later years. And then finally, because I'm just leaving everyone on a happy note, is I think one of the consequences that we don't quite realize yet is what the impact of the is going to have on trust in the health and public health system. Are folks going to trust the recommendations that are being put forth by these groups of supposed experts? Do we trust in the long-term benefits of engaging in the health and public health system, especially at the after all of these attacks on healthcare? And with that lovely note, I'm going to pass the mic back to Drew.
Thanks for that, Marianne, and also thank you to Jeff and Ronald for sharing that information. Next slide, please. There are lots of ways that we can work together to push back against the policies and cuts of the current administration and Congress. In the chat, we will be including some links to ways in which you can take action as soon as this call is over. One way is to write to your elected officials. AIDS United currently has an action alert on our website that will allow you to contact your senator as a member of Congress, telling them to vote no on all of the truly horrific cuts to HIV spending that were included in the House's fiscal year 2026 Labor, Health, and Human Services bill. After you're done with that, we also encourage you to use the link included to the right of that, the 5calls.org link from our friends at Save HIV Funding, to call those elected officials and remind them again about why those cuts are so damaging to ourselves and to our communities. Part of what you can be doing also is staying informed, knowing what's happening in Washington, D.C., and how it impacts your community and the folks that you know and love is incredibly important to any political activity. So we encourage folks to follow AIDS United and other HIV-related organizations, both nationally and in your state or locality, to follow latest developments around HIV policy and related policy, and also to sign up for any newsletters or alerts that can help you keep apprised of what's happening across the country. And then there are things you can be doing with your colleagues, with your peers, your friends, to spread the word about the ways in which this administration and Congress are really attacking the right to exist and to live full, healthy lives for people living with HIV, people affected by HIV, for racial-related minorities, trans individuals, the broader LGBTQ population, people who use drugs, people experiencing homelessness. If you're a marginalized community member, you are likely under the threat of one, if not more, actions from this administration and Congress. And the only way we can fight back is by coalescing around collective political will That means talking with your friends, with your family, about why these issues are important, about what's actually happening, as opposed to what they might be hearing from less trustworthy sources online. We are asking folks to continue to vote and to engage in voter education and outreach activities. This includes things around the upcoming midterm elections, but we also have off-year elections in about a month and a half. Some states have governor's races, some have city council races or school board races, various ballot initiatives. All of these elections are critically important to mobilize around, because political power doesn't just start with the president or with Congress. It really gets to start with grassroots action from everything as low as county commissioner. I guess we don't have dog catchers anymore, but those types of roles within city and state governments are still incredibly important in building power, and we need to turn out for all of these elections, not just the big ones. And the last thing is around organizing and building power. Our voices really are louder when we speak together as a collective, and there has never been a greater need for folks to come together and coalesce around a plan of collective action. There are a number of different organizations at the federal level that are leading this work on behalf of and in concert with people living with and affected by HIV. Some of them are national groups like AIDS United. Some of them, like the U.S. People Living with HIV Caucus, are community-led and community-driven. We encourage folks to engage with all of these folks, as well as partners outside of the HIV space that might be dealing on related issues, because it's only through this type of mobilization that we're going to make a difference. And we encourage you to reach out to anyone at AIDS United and the policy team if you have further questions about how to be involved, how to stay involved, because at the current moment, there are so many things right now that are deeply pressing issues, but that are competing for airtime. And we need to make sure that when we talk to members of Congress, when we talk to elected officials that are state and local levels, they're hearing from us not once, not twice, but all the damn time, because it's often the last folks that they hear from that are going to be sticking in their minds as they go into a vote or to craft legislation. And we need to make sure that our issues are at the very front of mind for them as they do their work. So I will pass it along to other folks. I believe, Mackenzie, will you be taking this next section for some brief Q&A, but also some information about AIDSWatch activities moving forward?
Before we get into Q&A, I did want to plug AIDSWatch. Our official save the date is out on March 16th to 18th of 2026, and the theme of this year's event is defending progress, demanding justice. As we encounter increased political attacks that threaten to dismantle decades of progress at the local, state, federal, and global levels, we must reflect on what our movements have won and demand what we are still owed. At AIDSWatch 2026, we will be discussing evolving threats, lessons learned, and movement building strategies, and then we'll bring those concerns directly to Capitol Hill. So I'll include a link not only to English and Spanish registration, but if we go to the next slide, our abstract process is open and it'll be closing at the end of October. Alongside that, if you're interested in a scholarship, whether it be for yourself or someone at your organization or someone in community, that process will open on October 1st and also close on October 31st. So a lot of things are in the works, and we're really excited to hear from you all, not only as potential scholars, but as potential presenters. And then we can move into Q&A. I know some questions were answered in the chat, but I really wanted to bring a specific question up to folks. When we think about AIDSWatch and bringing everything to the Hill, what piece of advice would you give to community members and advocates alike who are going to be on the Hill at AIDSWatch?
I mean, I can certainly touch on this, but I know that Ronald and Jeff and Marianne also have great answers, I'm sure. I think the biggest thing that we often talk to folks about is trying to be as authentically yourself as possible and talking about the real life impact of the policies that these members will be voting on your own life. They hear from organizations like AIDS United and CHOPE and the caucus all the time about the nuts and bolts of what's involved in policy, but oftentimes it is the actual emotional stories of people who are living with and affected by HIV that actually get through to congressional staffers and congressional members and make them become champions for these issues. And we also realize this is unpaid emotional labor. It is difficult. And some folks, particularly in this political environment, may not feel comfortable doing that. But for those who are, we really encourage folks to bring yourselves and your personal stories to these meetings, to these spaces, because that's what's really going to help move the needle for a lot of these members, in addition to the facts and figures and spending numbers that we're able to provide as well.
I would also add that keep being a squeaky wheel, like during AIDSWatch and also not during AIDSWatch, because your members of Congress work for you and they should get their directives from you. And that is every single day, every single week, and not just the couple days that we're in DC. Let them know your name so well that when they see your email come through, when they see you walk into their office, they know what you're here for, and they know that you're going to follow up on all the asks that you present.
And I'd like to underscore what our co-chair of the caucus, Vanita Ray, has pointed out, that meeting with staff is very important. Don't be hung up on you're not meeting with the member, but the staff, where much of the work gets done, is very, very crucial. So educating the staff along the lines that Drew talked about and hearing our stories, whether you're a person living with HIV or impacted by HIV or working, it's important to let staff members know what these issues mean to our lives and the importance of their educating the members of Congress. So meeting with staff is very, very valuable.
We also got a question from Antoinette Jones saying Congress will be on recess next week. How effective do you think scheduling meetings with House reps and senators will be, and what other suggestions do you have for people who are interested or new to in-district meetings?
I think during recesses, we often encourage folks to reach out to in-district staff to schedule those meetings for when the members are in state or in district, particularly if you have a good relationship with a member and are able to have them do a site visit at your clinic, or have some other way of interacting with your organization to see how you work on the ground, is always incredibly helpful. The other thing is that even while the members are in district, their staff are still working in Washington, D.C. So to Ronald's point, you can have meetings with in-district staff and with hopefully the members themselves at some point, but you also can still hold meetings with staff while the members are back in district to tell them the same things that you would want to convey to a member, perhaps with a more ready audience.
I also like what Lloyd put into the chat, and I'm not sure if that comment was directed towards this question, but if you're new to in-district meetings, I think it's a great idea to go to those meetings with folks who have participated and attended AIDSWatch before, especially if they have met with staffers before and can help you out on a first visit.
Wonderful. And just noticing that we're short on time, I wanted to flag there was a question about if we're doing anything in between Fall AIDSWatch and AIDSWatch 2026. In follow-up from this meeting, alongside the recording for this call, and just any follow-up that's needed, we'll be including our post-event survey and a listening session survey so we can hear from community before the event, which will help inform what we do. And again, that will all be included in a follow-up email. But with that, I'll pass it back to Drew just to give us a final wrap up. But appreciate you all and your questions. They're really insightful.
Thank you, Mackenzie. And just to raise up again, Mackenzie alluded to some listening sessions. Part of what we're looking to do with this is make sure that community is involved in shaping what some of the content is going to look like at AIDSWatch 2026. And so when we send out our follow-up, in addition to the post-event survey, we will be asking folks to share availability for these smaller listening sessions where you'll be able to sit down with staff from AIDS United, from the caucus, from CHOPE, to talk through some of the things that you are dealing with in your own communities and you would like to see content developed around for the big national event in March. And I also want to flag that, as Leslie has put in the chat, the applications for our latest AIDSWatch at Home cohort have been launched and are hopefully going to help us bridge that gap between fall and spring AIDSWatch and making sure that we have really targeted state and local action across the U.S. in different types of environments to push on legislative wins, not just in the Capitol, but in your state capitals and localities.
And if nothing else, that's a wrap. I appreciate